Cool. All right. So I am part of a working group on mobile stroke units, and and I have to say, I think one of the reasons for that is because my background's anesthesia, not emergency medicine, and I tried to palm it off, and I was unsuccessful. And we'll sort of show why, I think, shortly. Um, and one of the reasons I'm doing this presentation is I actually get quite a lot of comments about it, and basically comments such as this. So there's no evidence that they work. Stroke thrombolysis is a waste of time anyway. Why take the CT to the patient? Why don't you just bring the patient to the helicopter? Sorry, take patient to the helicopter, take patient to the hospital. If they need endovascular retrieval, why don't you just take everyone to an EVR centre? Wouldn't the money be better spent making in-hospital stroke treatment more efficient? So they're not actually unreasonable questions, but I guess part of the reason I did a bit of a survey of the literature and presenting it here is because I couldn't answer those particularly well. So really, this is just a way of me trying to communicate back, answering those questions, and just trying to look at another aspect of pre-hospital care, which we're not involved in, which may well become more prominent in the future. So just a reminder to people about levels of evidence. So when you are looking at studies, there's the old triangle thing here, which I think most people are now familiar with. So background information experts at the bottom, observational studies, randomized control trials forming the middle bit, and then of course systematic reviews and meta-analyses at the top. I'm not quite sure where Twitter or Truth Social fits in. I think a lot of people actually put it right at the pinnacle, and I'm not actually against that entirely, because you could argue that it's filtered by experts, right? But then some people would argue, well, that comes back down here to expert opinion. So I used to be more, I guess, slightly rude about this, but I kind of get where some people are coming from when they do sort of don't read any of this and they just go straight to Twitter. But maybe it does have a role. I'm not convinced, but I'm not totally out either. What I do have is I think of this sort of thing, especially when you're reading research, as more of a continuum. So this is the Miller continuum evidence. It's a work in progress. And I thought when I read a study, I think of a number of dimensions, actually. I don't think of it just straight triangle. So I think, well, where does the strength of evidence lie for the study I'm reading? Is it low or is it high? But then there's also the narrowness of the population, the narrowness of the intervention. So some of them focus on really, really specific things, and some of them become more broad. And then is it generalizable to me? So a bad meta-analysis probably actually ends up down here, really. It's probably worse in terms of strength of evidence, in my mind, to a non-randomized controlled trial. A good observational study is sometimes, when I read it, better than a non-RCT, especially if they've managed to try to control thing and use some fancy statistics stuff. Obviously, a well-done randomized controls trial sits higher up, and then a good meta-analysis is obviously the best level of evidence. But then when I think about generalizability, to me, sometimes a good observational study is actually more relevant to the practice I do than a well randomized controlled trial. So if I think back, and Darragh mentioned it, the refill trial, I thought actually, all things considered, the design wasn't too bad. I think from the results in the study population that they captured, I don't think it's very generalizable. So it's one of those ones that you could argue on the triangle. It's reasonably strong evidence, but actually usefulness, it's down here. Right, and so that's why I think of it more on a continuum. And when I was reading through the commentary around stroke thrombolysis, this came to mind for me because there are people very much in different camps, and I think one of the reasons is because people are confusing strength of evidence with generalizability and with narrowness of the intervention. So I'll move on to a completely unscientific part of the presentation there. Here we go. So what is a mobile stroke unit? So generally, it's a vehicle of some description. It has a CT scanner in it. It has point of care lab testing and some reversal agents for anticoagulation. There's usually an advanced care paramedic or two on board. There's a stroke clinician, so that can vary. It can vary from a neurologist, which is obviously very expensive. In Norway, it's actually an anaesthetist who's had special training by neurologists in pre-hospital stroke evaluation. And more increasingly, it'll become probably a clinical nurse specialist with telemedicine support to a stroke neurologist sitting in a hospital who's also looking after multiple sites to sort of make it more cost effective. There's obviously a radiographer to run the CT scanner. You have to have good telecommunication suite, obviously, because you've got to get all these fancy images back to the neurologist, and the ability to provide on-site stroke thrombolysis. So these are just some photos of Melgold stroke units around the world, and they vary very much in size. I'm pretty sure this is a European one. CT scanner, obviously places for people to sit, little lab thing. There'll be a fridge here for some prothrombotics or some blood products, reversal agents, and general ambulance-y stuff on board. This is an American version. This is a very American version, so big, long truck. Probably fits nicely in nice, wide American roads. Wouldn't work very well in London, I don't think. And this is the Melbourne one. So the Melbourne one they managed to actually get it into a nice little compact unit, but it's not capable of perfusion scanning. So this is the MSU one. So it can't do CT perfusion, unfortunately, but working on that. And this is the future. So when I Googled it, I found this. So Scandinavians are trying to put a CT unit in a helicopter. I'll just let that sink in for a bit. There's some interesting design problems or challenges, and one of which is the lead lining. So sometimes the reason for these massive chassis is not actually, because that scanner is not that big, right? But sometimes it has to go into a chassis the side simply because of the requirements for the lead lining. So the weight of the lead lining puts the weight of the whole unit above what this little fella can take, and so you end up having to get a big truck simply to cope with the lead or the radiation insulation. The other problem is that the temperature inside the where the CT scanner sits cannot go above a maximum temperature of I think it's around 26 degrees or something like that. So you can't leave this parked out on a Sydney summer day without it being continually air conditioned, which I'm not quite sure how you would work that in. I just look at the windows and think those are going to have to be lead lined. I can't imagine the weight. But anyway, obviously it hasn't happened yet. But as these units get smaller, I'm sure it's a possibility. So here's mobile stroke units. So they're actually located all around the world. The US has the most. There are proposed ones. Oh, sorry, France and Germany. They are probably around the first. Norway, obviously. There's planned ones in other places in Europe. One planned in China, and of course the current one that's located down in Melbourne. So I guess one of the first questions is why would you shift stroke to the pre-hospital phase? And I think one of the things you sort of realise this is not an area of practice I'm ever involved in, but most stroke patients don't die. So the mortality from acute ischemic stroke is only around 3 to 6%. But you get a lot of disability from stroke, which is obviously affects patients and affects healthcare costs. And as you get older, the proportion of disability caused by stroke is huge. So obviously you can treat this earlier and hopefully in effective means, you can obviously reduce worldwide disability and healthcare costs. I've just taken this from, it's actually a reasonably old study, but it was one of the only ones that sort of graphically depicted, this is onset time to thrombolysis and outcomes in terms of where the patient is independent, required assistance. And it just tries to show that the earlier you can thrombolyze, the increasing proportion of patients who benefit. It's not actually much if you look 38 and 45%, but
attention please. QT all staff, any contractors, visitors may have attention please. We're about to testify on our boarding system.
Excellent.
Please disregard all sound smells.
So frustrating.
Please do not evacuate. I repeat.
This will take a minute or two, Matt. Sorry.
I'll
just chill. We get to sing along with that.
Are they going to actually do the whoop whoop? I'll keep talking to the whoop whoop.
No, stop a sec, because that way I can fix the recording later.
Oh, okay.
He's just going to keep talking like this for 2 minutes or something.
Okay.
Yeah, if anyone needs a toilet break,
Yeah,
time to take a toilet break, seriously, it's to go on for like 3 minutes. It's so frustrating. Apologies to everyone online. We are just having a small pause while they test the fire alarms for the 57,000th time. And they've always worked. No, not worked.
But the problem is, how are they testing it? They're pushing the button. We need to start an actual fire to make sure.
You Americans, man. You Americans. We're not taking any more advice from Americans.
We have tried that.
Yeah.
At the Orange House, the shower sits up.
That's it. Yeah. When he's finished, he'll do another announcement and say, everyone get back to your work, and then we can get back to the talk. But thanks to everyone who's online. We've got about 25 people online, which is great. As we're in this new COVID universe of everyone being online. And we'll make the recordings available in a few days after. But it just helps if I can cut this little section out when we edit them. So just hang tight, Matt, sorry.
Yeah, that's right.
While we're talking, some community announcements. If you have not had your flu vax, you need to get your flu vax done. We're now entering flu season and there's large numbers of people getting flu. And we need to record everyone's flu vax, and it's a mandatory vaccination. I can see when I look at the records, there's some people that haven't recorded it, whether they've had it or not. If you get your vaccine done somewhere else, you need to let StaffLink know, and there's an email that's been sent around, but otherwise email Carissa O. She can also record it for you. If you haven't had it here, make sure you get the DRC to do it for you at the end of your shift or on a non-clinical shift, or after a night shift, for example. At the moment, we're not letting people get vaccinated while they're clinically on a shift in case they get some sort of reaction, but we do need everyone vaccinated. An education day would be an excellent time to get vaccinated if you weren't clinical. Perfect.
Does it need to be recorded anywhere other than the sheet that you fill in?
No, that sheet goes back to ambulance. So if it's done here, that will be recorded. But I would take a photo of that sheet for your own records in case anything goes wrong. And exactly. But this guy comes back online in a second. As soon as I say let's get back to it, he'll come on with the rest of the alarms. Don't mean anything.
Well, I'm just going to update my StaffLink while you guys are waiting.
Yeah, it's frustrating. He usually comes back with the everyone get back to work. I'll let you go back, Matt, and restart, and hope he doesn't interrupt, but knowing that he will.
Yeah, I'll stop as soon as he starts talking. So I've just completely messed up my screens. Hold on. Can you see my StaffLink or the slide? Oh, you can see the slide. Good. So this was an older study, but this is where the early thrombolysis, the push to try to do thrombolysis early came from. This was actually a large, big data study. So there's about 60,000 patients involved in this. So that's why you suddenly, when you do these big data studies, you can find quite, you can easily get a significant p-value with a smallish difference. But if even 38 to 46% difference in good outcome for earlier thrombolysis, if you do think sort of worldwide or the global burden, it's quite a lot of people. So, but this is really where the movement to try to get earlier. So they borrowed the term golden hour. So this is the stroke golden hour. Now, if you speak to anyone who's read around or done any postgraduate reading around trauma in the golden hour, most of them will just be sitting with their head in their hands, because the trauma golden hour wasn't really actually ever based on outcomes. It was based on insurance. And some guy made a flippant comment and the newspapers picked it up. But maybe in stroke, the golden hour is actually slightly more relevant. So I did a survey of really more of a survey than a critique of every paper, because there's a lot of papers out there looking at the evidence between stroke thrombolysis and initially in MSUs, because I think that understanding the background and some of the controversies around this is quite important to understanding where MSU stand and some people's reluctance or I'm trying to think of the word for it, some people's skepticism, right? And so and it's quite frankly, I have to say, coming from an anaesthetic background and looking to this, it's an absolute minefield. But if you Google minefield and try to get a picture these days, you just get horrible pictures from Ukraine. So I've got a person trying to walk over Lego instead. So I think what's really interesting is the outcomes that are measured. So there's time to thrombolysis and time to CT. So there's actually lots of time metrics in any of these papers. And It wasn't until I went back and saw that original paper I can see why. So there's this push to do early thrombolysis. So you'll quite often see thrombolysis within 60 minutes or within the stroke golden hour as outcomes in the randomized controlled trials. There's various measures of mortality, and then there's the modified Rankin score, which is this here, which is really the outcome measure. And what they're looking for is basically two or less, because you're looking at slight disability, but you're able basically to discharge home and look after yourself. And anything sort of three or higher is sort of considered a worst outcome. So these often appear the modified Rankin scales, or there's the weighted, it should be the utility weighted modified Rankin score is another one. And then also there's the number of eligible patients receiving thrombolysis. And I can imagine that if you weren't a thrombolysis fan, you wouldn't consider that a great outcome. But if you were, obviously that's why it's often reported. So this is what you see in the papers. The thing I found quite interesting is that severity of presentation is measured by, there's a variety of scales, and this is just one of them, National Institutes of Health Stroke Scale, and there's a lot of measures on it. And when I was looking at it, I wanted to see, okay, if I have a stroke and I have thrombolysis, how many people go from a certain level of severity to a better level of severity? How much am I going to improve? And it's actually really hard to work out, because there's a different scale for eligibility for stroke than there is for outcome. And often I couldn't see anyone who reliably reported it. So I think that's probably partly where some of the confusion comes from. But the reason the severity scales are so important is that the symptomatic intracranial hemorrhage, which is obviously the thing you want to avoid when you thrombolyze strokes, gets higher. The proportion of patients gets higher with the more severe your stroke is. So the higher your severity of the stroke, the more it is a relative contraindication to actually receiving TPA in the first case. This.
Testing the fire alarms is now completed. I repeat, testing the fire alarms is now completed. Thank you.
Excellent. I wanted to bring this graph up because I thought it was actually a really pretty graph. Although it takes ages to try to work out how you're supposed to interpret it. But this is like function. It's called the Fugel-Meyer upper extremity score. It's basically a recovery of function. And the number of patients who recover function over time, but they've actually put it down here as weeks. And it's your initial score and your improvement. So obviously, patients with a milder deficit, which is these purple guys, they obviously have a quick and good recovery. And the more severe deficit obviously have a slow and less recovery. But interestingly, there are a number of patients here who have reasonable deficits, this is the green ones, who actually over time actually get reasonable long-term recovery. So one of the outcomes you see is the Rankin score at about 90 days. And I was thinking, well, stroke, is 90 days long enough? But actually, it looks like about 50, if you look at this is like the 50% recovery on the curve, is about 10 weeks post-stroke. So about 12 weeks for the people who are going to recover, you actually have most of them having recovered. So 90-day modified Rankin is also one of the outcome scores that are often used. So again, trying to delve into this and look at stroke thrombolysis, I used to go to NNT a lot actually when I would like to just get a quick review when I couldn't be bothered reading anything. But the problem with the internet, or the problem with the NNT, is it depends on which one you click on. So if you click on thrombolytic acute ischemic stroke, they say no benefit found. That was their first review. But then their second review actually showed TPA was good. And then they updated it and they said, actually, no, we're uncertain. We're in the 50-50 mark about whether it's good or bad. But you can click on any one of these, and if you don't click on the other, you'll just get a different response, or you'll come up with a different conclusion. Part of the problem is the 2021 update uses a 2016 review. So even though it says updated in 2021, that's the review they use. It's back in 2016, so it's now 7 years old. But actually, if you look up, so I did a search, thrombolysis for acute ischemic stroke, looking only at systematic reviews and looking at just the last 4 years, you get 193 results, but you don't actually get new updates about stroke thrombolysis and placebo-controlled trials. So I think part of the reason is that they're just not doing them anymore. So people are now interested in TPA versus tenecteplase. They're interested in wake-up stroke and all that sort of stuff. So the reason there's been no new systematic reviews is people aren't doing a placebo-controlled trial. And I think you would struggle. And one of the reasons is if you're in the camp of a neurologist who thinks or is in the camp that thrombolysis works, I think you're unlikely to then agree to a placebo-controlled trial. Whereas if you're in the emergency physicians and you want to run a placebo-controlled trial, I can't imagine a ethics committee giving you permission to do it without a stroke neurologist on board who's probably going to say don't do it. So I think that there's probably I wouldn't say necessarily political, but there's a structural background to maybe why we don't see many more placebo-controlled trials coming out. So from my reading through the literature and reading through the commentary, there's a real problem with interpreting thrombolysis, stroke thrombolysis. I think that from what I've read and listened to podcasts while preparing this talk and looking at systematic reviews, if you don't agree with thrombolysis and acute ischemic stroke, I'm not going to convince you otherwise. And I think you're unlikely to be convinced. I think one of the really interesting things is the criteria for thrombolysis include potentially disabling ischemic stroke, but this doesn't actually get defined much further. So there's actually when you look at some of the guidelines, there's no clear scoring system that says X or below or X or above or within the sort of the 5 to 7 NHISS stroke scale. So that probably contributes to a lot of the difficulty interpreting the data. In general, though, there seems to be a net improvement for the number of patients with a modified Rankin score of 0 to 2. But there is much debate about the quality of the studies, and there is much debate about how to communicate the benefits of the studies to patients. And it is actually an ongoing area of research. And so sometimes in situations like these, it's actually easier just to look at some position statements and expert guidelines when there's this uncertainty. So I did go to, so if you are ever looking up anything on any topic and you want to see whether there is stuff going on, you can go to clinicaltrials.gov. I've just done a search here for thrombolysis versus placebo, interventional studies for stroke. There's actually 56 ongoing studies at the moment. But when you do click through them, most of them, this is actually one here. This is the only one I found that was truly tenecteplase versus placebo. Here's alteplase versus placebo, but they're looking at wake-up stroke here or extending stroke. So a lot of them aren't actually looking at they're looking at how far out can you safely thrombolyze and whether it causes any benefit. So this sort of comes back to I don't think you're going to get any more placebo-controlled trials for that 4.5 hour window, which most people are talking about. So out of curiosity, what do the guidelines say or consensus statements say? So ASIM actually have a position statement that they update every 3 years, and it's a bit wordy. They repeat the literature review, and they haven't changed in 3 years, pretty much because there's been no recent systematic reviews or randomized controlled trials. But they generally talk about the communication of the benefits and the risks, and they advise thrombolysis only where there is obviously qualified stroke service, and advises that there are concerns about the quality of the evidence. So this is actually their recommendations. I've just put the big arrow because they talk about communication, and this is one of the ways they suggest talking about communicating to patients. And I don't know, I can't really understand it. I mean, it's numbers needed to treat, obviously, but I think if you're a patient and someone says, your chances of modified Rankin score of 0 to 1 is 10, whereas the number needed to treat is 10, whereas if to get functional independence, it's actually 12, and that's 42 if you're going to get a hemorrhage. I don't know how a patient could actually try to put that into context. Interestingly, I think this is quite an interesting line. There's disagreement about the strength of evidence. I actually think that probably should be modified to say there's disagreement between us and neurologists about the strength of evidence, because I think the neurologists are pretty happy with the strength of evidence, whereas I think others are not. So, and so they recommend ongoing reviews, replication of research into stroke thrombolysis, but I don't know how likely that is, as I said before. Interestingly, generally, so from what I can see, European and Australian stroke statements are generally aligned. So up to 4.5 hours, if you meet the criteria, they suggest you get thrombolysis. Up to 9 hours with large vessel occlusion and perfusion mismatch, you could receive thrombolysis, and wake-up stroke of indeterminate onset, and you've got CT, or in some cases MRI evidence, you could have thrombolysis. So that seems to be roughly where Europeans, Australians, and Americans less so for the wake-up stroke, but seem to generally be agreed. So if the controversies around stroke thrombolysis leave you somewhat unsatisfied, I thought I'd just have a quick look at another way. And I think, well, what do patients want? So I did a little research for patient and what patients actually wanted, and whether they would want to be thrombolyzed. And interestingly, none of those position statements, well, some of them do, but none of them actually really are patient-centered. They're all outcome-centered based on randomized controlled trials and really hemorrhage risk. Of course, the problem with these are all surveys, and I always stay away from surveys because I think they're very, very difficult to design and they're full of bias. But it is interesting because this is one. It's 300 patients. It's actually published way back in 1998. 45% of respondents considered major stroke to be a worse outcome than death, and 15% were willing to trade off little or no survival to avoid a major stroke. So it's just interesting that there are patients out there who would be pre-stroke willing to take the risk. This is stroke patients' views on stroke outcomes, death versus disability. I think this is a small number now. We've only got 28 patients in it. But interestingly, 69% of stroke patients and 82% of controls rank death as preferable to severe disability. Unfortunately, severe disability, of course, almost excludes you from having stroke thrombolysis. But it's just interesting that, again, elderly patients would rather die. But however, the interesting side note here is that stroke patients may be more tolerant of disability. So your opinion seems to change if you've already had a stroke and you realize maybe it's not so bad to live with said stroke. So it's not that straightforward. Another thrombolytic treatment for stroke, patient preferences. Again, 9% would accept thrombolytic treatment for mild stroke, 87% for moderately severe stroke, and 97% for severe stroke. So the patients seem to want to have some thrombolysis. Inability to consent. So this is if you can't consent. And these guys asked people basically comparing getting CPR or as thrombolysis. And basically as many patients, if they're unable to consent, wanted thrombolysis as who could consent. And that was comparable with people who did or didn't want cardiopulmonary CPR. So it is interesting. So if you look at it from a patient point of view, it seems to me that patients may actually be willing to accept the risk and have stroke thrombolysis. Finally, and I just found this quite interesting, systematic review of malpractice litigation and the diagnosis and treatment of acute ischemic stroke. I know there's lots of problems with looking at malpractice studies, but I just thought it was kind of interesting. And so interestingly, this is in the States, 246 cases of litigation in the time period that they looked at, 71 cases were actually related to failure to thrombolyze, and only one was actually related to symptomatic intracranial hemorrhage post-thrombolysis. And the commentary here is that they found this interesting, and that the discussion and the consideration of thrombolysis should be forefront of the clinician's mind. And as we go to endovascular clot retrieval, offering that as a service is probably important to patients. So back to the MSU. So the stroke thrombolysis, from what I can see, people on one camp or the other, the information is probably not going to be updated. It seems to offer some benefit, but it's not without risk. So the potential benefits for a mobile stroke unit, of course, early thrombolysis and early identification for people for endovascular clot retrieval. And that's about getting these people into the trying to shift as many people into the earlier than later stroke thrombolysis category. So there was a systematic review actually done of mobile stroke units back in 2020. And I'm not going to talk about this anymore because this just used time measurements. So when I first got introduced to the mobile stroke unit, this is one of the first ones I looked up. And it really had nothing to do with patient outcomes. Patient-centered outcomes is all about whether time to needle. And I, to be honest, wasn't all that convinced. But this is what one of the papers showed, sort of a 2008-2011 trial done in Germany. If you look at time to stroke thrombolysis, 57% of patients, the MSU, got their thrombolysis within 60 minutes, whereas only 4% of controls. And if you were a believer in thrombolysis, obviously that's quite an important metric. So I can see why people were excited. Recently, however, in the last year, they published two controlled trials, not randomized, but controlled trials of mobile stroke units. So one was based out of the United States, and it had mobile stroke units and EMS working week on, week off during daylight hours. MSU was the versus you got standard mobile stroke unit care. EMS, you got standard standard EMS care. So that the ambulance comes out, brings you back to the hospital, and you see the stroke team. But the MSU nurse actually just grabbed the patient, or identified the patient as they arrived in the hospital and just performed an assessment for baseline variables to try to match these, because of course, if your stroke was worsening, you would end up with a worse patients in the EMS group versus the MSU, and it wouldn't be a fair comparison. So they tried to sort of back calculate without interrupting the flow of the patients to try to work out if the MSU had arrived at the patient side, what would be their disability to try to get some try to make the groups as balanced as possible. They enrolled all patients who were screened as eligible for TPA, and outcomes were the percent eligible who were treated, some time metrics, and some short and long-term functional outcomes. So, oops, that's not very good. That'll excite some people. I just went straight to the end of the talk. Right, I'm just watching it in the delayed feed. Here we go. Excellent. So when they looked at it, try again. Here we go. So they looked at eligible patients who got treated. 97% of eligible patients got TPA, whereas only 80% of emergency medical services. And then when they looked at all enrolled patients, so the enrolled and eligible were slightly different. Enrolled meant you were screened eligible, and eligible actually was based on your CT scan, because obviously if you had an intracranial hemorrhage, you wouldn't get a thrombolysis, so that's another factor. And it's about the same. You know, the differences are similar. So more patients receiving thrombolysis than not in the MSU. And then the outcomes, I think, are the most interesting, in that the good and excellent outcomes were more often seen in the mobile stroke unit. So nearly 40% versus 25% with modified Rankin discharge disability free. The numbers sort of disappearing as you get to sort of the modified Rankin scale. The difference, of 2 or greater. There's not as great a difference, but certainly in the excellent outcome group. Time metrics, time to thrombolysis 72 versus 108 minutes. So more patients thrombolysed within an hour than this group. So their statement is, on average, for every 100 patients treated in the MSU rather than a standard illness, 27 would have less disability, and 11 of those 27 would be disability free. And that's not bad. This is another one. This is published about the same time, kind of similar study. It was done in Berlin. Simultaneous dispatch of an MSU and versus just conventional ambulance alone. Reasonable numbers, right? 700s. The previous study had about 1,000 patients in it. And similar results to the best MSU study, which the study said before. More patients with excellent outcome, more offered and received thrombolysis, and more thrombolysed early, and no increase in mortality between the two groups. I'm just flicking this one up very quickly, just so Melbourne is actively involved in research with their one. They've got this terribly named paper, Taste A, which was comparing TPA to nectarplays, but they managed to get it published in the Lancet. Oh, I don't have the journal. Anyway, go to the and the only reason I say here, the only reason I bring this up is I don't know, it's a terrible named study. But all they looked at was actually perfusion volume lesion. They didn't then looked at harms. They didn't actually report. It's probably hidden in the detail, but I couldn't find it. They didn't report whether the outcomes were better, but the outcomes were certainly no worse for patients treated with nectarplays. So finally, I'm almost at the end. Finally, systematic reviews. So after those 2 RCTs of systematic reviews, 2 systematic reviews of mobile stroke units have been published. This is one of the first ones. It's in Frontiers in Neurology, and I'm going to click past it because basically I found it very difficult to read. So luckily, JAMA Neurology also did one, which is a lot easier to read. And they compared mobile stroke unit with usual care for acute ischemic stroke, systematic review, and meta-analysis. I've just cut and pasted because at the end of the day, I think, again, it's these same similar outcomes, right? Modified Rankin score, excellent outcome at 90 days, which seemed reasonable. And the odds ratios, they're not huge, but they do show improvement in excellent outcome for patients treated by a mobile stroke unit. These are sort of the adverse outcomes down the bottom here, and there was no difference between mobile stroke unit and standard care. And again, here we've got intravenous thrombolysis within the golden hour. So obviously, the odds ratio is quite high for that because you can thrombolyse the person in their driveway. One of the reasons to say good versus bad systematic reviews is, and I always say to people, you've got to go to the tables to have a look at when you're looking at any study rather than just relying on the abstract. As I did actually go through the tables, and when you look at the MSU, this is the table of functional outcomes at 90 days. So this is showing MSUs in the systematic review had a better outcome, better rate odds of a excellent outcome. There's this study here which shows no difference. and I hadn't seen it before. So I went and had a look back and had a look at it. And interestingly, that study is not really about MSU versus standard care. It's about actually screening. But they've incorporated it in here because it's a randomized controlled trial. These are sort of the non-randomized trials here, and these are some observational studies. So this systematic review incorporates good observational studies, non-randomized controlled trials, and randomized controlled trials. But the RCT that they incorporated, when I read it, I didn't actually think it really fits it in here. So I sort of agree with the benefits. Maybe they're slightly larger than it's reported, and this guy here, which has been included, I would have excluded it myself. So I think that's why I keep saying to people, you need to go back and look at the figures rather than just look at the abstract. So what is the bottom line? So my bottom line is if you don't agree with thrombolysis and stroke, you're unlikely to agree with the mobile stroke unit. And from my survey literature, that's probably not going to change in the short term. Patients may be willing to take a risk that some clinicians are not, but that risk may change if it's your first or your second stroke. Mobile stroke units lead to earlier thrombolysis in more eligible patients. And then I take you back to the first point is if you don't believe in thrombolysis, that's completely irrelevant. But if you do, it seems like a very, very good measure. Mobile stroke units appear to lead to increased odds of excellent outcome. But this is really only early evidence from non-randomized controlled trials. Although I don't know how you do an RCT in a mobile stroke unit. So back in 2019, I would have said with mobile stroke units, I don't get it. And in fact, I did say that in a large audience, including neurologists. But I basically said it based on the literature at the time. I don't see where the benefit lies. But I have to say in 2022 now, I'd say it's probably worth giving a go, but it would need continuous reevaluation.